Hello.
Sorry, good afternoon. I hope you can all hear me. My name is Dr. Rhoda Kalandu from Kenyatta National Hospital. Today we're excited about today's topic. We're talking about home-based care in Mombasa County. And I can see that the presenters are already with us. Weekly for Monday, you don't need to send us your details. You already get your details once you log in, and the system remembers you every time you log in for the session. Hello, Mariana, Anto, and Joan Mukoya. We are starting now. Dr. Sud. Hello, Dr. Sud.
Hi, how are you, Rhoda?
I'm very fine. It's good to hear from you today.
Thank you.
Yes, and I can see also Dr. Arif Bhavani is with us.
Yes, Dr. Arif is there.
Yes, so I'll let you start the session. And to the rest of the participants, please remember to put your Q&A, your questions in the Q&A section, or any feedback you have for the team in Mombasa. And I hope we all have our notebooks ready so that we can see what we can implement from our side or wherever we are. Dr. Sud, I'll let you continue.
I will leave Dr. Varvani to start the presentation.
Okay. All right, good.
Good afternoon.
Good afternoon, Dr. Varvani.
All right, my name is Dr. Arif Varvani, and I'm one of the students of Dr. Sud, who is the best mentor I've ever come across, I would say. So to cut the long story short, we are from Mombasa County. We man the Coast General Teaching and Referral Hospital COVID-19 Isolation Unit, and we are here today to share our experience regarding home-based care. So without much ado, let me start sharing the screen. Just a minute. Yeah. So. And right. So are you all seeing the screen?
Yes, we can see your screen.
All right. So this is a presentation based on the Coast General Teaching and Referral Hospital, our plan for home-based care of the COVID-19 patients. My name is Dr. Arif Farvani, and as I clearly indicated before, that Dr. Sood is my mentor, and he is the consultant in charge of the COVID-19 isolation unit. So this is how the presentation will be. It will be more of a discussion session. And these are the outlines, very few slides we have. Just to introduce, back at Coast General Teaching and Referral Hospital, since our first suspected case of COVID-19 was admitted on the 1st of February, we have had over 300 admissions, both suspects and confirmed cases. However, from the 300 admissions, approximately 88% have been asymptomatic. And obviously, due to the HR issues, we were having issues managing them all at the hospital. So home-based care of COVID-19 patients is actually the game changer, as it has greatly reduced the stigma and anxiety among the stable and asymptomatic patients. So this is the current situation at our isolation wards. Currently, we have only 20 patients. So if you look at the demographics, 15 are males, 5 are females. This includes the suspected cases. We have 6 suspected cases, and results have just come in right now. One of the cases is actually negative, so we are discharging her. So we'll now have 19 patients left with 5 suspected. At home currently, for the home-based care, we have 104 patients who we are following up from home, and we'll discuss about that shortly. So let's look at the demographics. If you look at the gender, you can see that generally across all sub-counties, the males are outnumbering the females by far. So we have more of males being affected as compared to our female counterparts. If you look at the gender as per the age group, again, the same thing. Just that the age group of 0 to 10 is where the females are more, but generally across the board, you're seeing more of males affected than females. And if you look at the symptomatic cases per gender, so the blue are those without symptoms, and you can see female 30% are asymptomatic and male 57% are asymptomatic. So we have approximately 88% who are asymptomatic. Again, males outnumber the females by large. So let's look at the discharge criteria. So after getting the green light, and based on the guidelines which were set aside by WHO and the Ministry of Health from Kenya regarding home-based care of COVID-19 patients, we also reviewed our discharge criteria. So we now expanded our discharge criteria. So a patient to be discharged home for 14-day self-isolation after having tested twice negative, but these have to be consecutive negative tests, and they have to be 24 hours apart, samples which have been taken 24 hours apart. Again, if you are to discharge an asymptomatic patient, now number 2 is the new criteria that we brought about. So if you have an asymptomatic patient to be discharged home for self-isolation, after failing to fulfill number 1 above, after a total of 4 repeat tests, or after having completed 21 days stay within our isolation unit, whichever is longer. Now we understand that the WHO said 10 days, then we said 14 days from the Ministry of Health, but we were trying to play safe and we extended ours to 21 days because of obvious fear that there might be some continued viral shedding, and you have to take care because of the logistics, as we'll discuss later. So these were the SOPs that we made for discharge. So every case was discussed individually. We formed a home-based care surveillance team. So one thing that has really worked for Mombasa County and Coast General Teaching and Referral Hospital in particular is teamwork. So we have a very vibrant team. We have youngsters in the team, and it's a multifaceted team. It's not only doctors, it's not only nurses. We have a team of all cadres. We have doctors, we have nurses, we have public health officers, we have nutritionists on board, we have lab techs on board, and we even have our dear consultants. The public health officer was to verify the residence of the patient in order to ensure that it actually meets the requirements set aside by the MOH guidelines. Now remember, the residence, there were some key issues that we will discuss, and I will discuss in detail with you, that need to be verified in the residence before the residence is deemed fit for self-isolation. Then the rules and regulations were clearly to be explained to the patient, and the patient was to sign a self-isolation declaration form. Now this has actually shown a big impact, because you see, most of the asymptomatic patients feel that they are not actually sick. There are a lot of theories going on that this is it's not something true and what have you. But after explaining to each and every patient one by one, and they have to actually read through the form and also sign, it's really created a big impact. And I will show you from the follow-up tests of the patients. Then we have a designated vehicle to transport the patient to their own residence, because we can't allow them to just go in a private taxi or a private car. And then a scheduled follow-up by the home-based surveillance team. And we also made sure that we had dedicated hotline numbers, or we had a proper channel of communication between the patients, the households, and the team at the isolation unit. So, as per this morning, the home-based care patient demographics, we have 104 patients, as I had earlier said. 54 are males, 50 are females. So we have been following them up. We have been testing them weekly, and as you can see, 34 patients from the 104 are yet to be tested. 32 are awaiting results. Some of the results are just trickling in right now. 35 have already turned negative, and 3 have still tested positive. So imagine when they were in hospital, they were still turning positive repeatedly. But what we have seen is when we have sent them home and on repeat testing, most of them have started turning negative early compared to what we had before home-based care. And that is a good sign. So the guidelines set aside by the Ministry of Health, there was a checklist which we had to make sure that the residences fulfill, and this is what we were using to evaluate the residents. So it's basically it's a 5-pronged approach. So the first thing is infrastructure. Is infrastructure available? So if you look at this, let me expand this. So in the infrastructure, they had to have a functioning telephone or mobile phone, or any other means of rapidly communicating should there be any emergencies. They should have water, both drinking and cleaning water, good sewerage system, cooking source, because you see they will have to, if they are alone, they have to cook for themselves, yeah. Electricity and adequate environmental ventilation. So ventilation is also key. So this was to do with infrastructure. Then accessibility. How accessible is their place? Is their residence? Yeah. And then the third prong was accommodation. Did they have a separate, well-ventilated room or bedroom for the patient, or were they living in shared rooms? So you see, again, you cannot put someone who is still positive, though asymptomatic, in the same room with someone who is tested negative. And then did they have a particular accessible bathroom? Now, this was a very big challenge because some of the patients do not have self-contained rooms. So if they were okay with the guidelines that were saying that they can actually be taught how to disinfect the washroom or the bathroom after use, then they were taught and they were let to go for self-isolation. If not, then they actually stayed back at our facility, and that's why we still have some few asymptomatics in our facility. And then resources, food. Main thing was food. Then there was medications. Then again, the other protective equipment like surgical masks, face masks, gloves. If there was someone who needed to have a caregiver by their side, then are the gloves, the masks, the coveralls, and the aprons, and what have you, are they available? Hand hygiene supplies like hand rubs, sanitizers, and even the general household cleaning and disinfection items. And then the last thing was the primary care and support. Did they have people around them who are actually the household members, and they are actually going to provide the support and care? And then the main issue was this last one, which let me just expand it. And here it is. Are there any at-risk people at home? Now, there are those at-risk individuals, individuals who, if they should contract the disease, we have to be very careful because they can actually get a fulminant cause of disease. Are the elderlies above 65 years of age, immunocompromised patients, patients with other comorbidities which are poorly controlled? So if they are there, then there had to be a clear-cut demarcation that those members would not be allowed to have a very close contact or interact, because obviously then that puts them at risk. So transportation, as we had earlier discussed, we had to have a dedicated ambulance, which only serves the purpose of transporting COVID-19 patients and nothing else. So we have an ambulance, and this is dedicated only for COVID-19 patients, obviously because we don't want the risk of contaminating or cross-contaminating with other patients. And now, hotline contacts, the channel of communication as we had earlier discussed. So we have dedicated 2 phone numbers, and we are looking into getting more, so that as we increase our base or our numbers at home for home-based self-isolation, we can have more people to follow them up, and because we don't want them to try and call a number and it is busy, yeah. So there are 2 phone numbers which are dedicated for follow-up, and they are as depicted on the screen. And these numbers are switched on 24 hours a day, 7 days a week, and until and unless this pandemic is over. So you can even try if you call right now, and someone will pick and assist you accordingly. Then follow-up of the patients who are on home-based care. The patients are expected to report any symptom to the hotline numbers promptly. On the other hand, the Department of Public Health has scheduled a weekly test. So remember, if you are sending them on home-based care, that's not the end of it. Some people can, they can get worse. They can turn from asymptomatic to symptomatic. They can turn from mild to moderate. So we have to do close follow-up, and we teach the patients through the self-declaration, the declaration for self-isolation form. We explain and we impart education to them, what they need to be checking. If they have thermometers, the better, because they'll be writing their temperature at least once or twice a day, every day. And if they see a spike, they need to inform the doctors and the surveillance team on the ground. And on the other hand, the Department of Public Health schedules a weekly test for all the patients. And that is the graph I had shown you about the repeat test. So obviously, every good thing comes with its challenges, and home-based care, though seems as good as it is, it's also been rosy. Rosy meaning that it has a lot of petals, very nice petals, but there are some thorns as well. And these are the challenges that we will discuss. So these are the challenges. One, stigma. So due to the misperception of COVID-19 among the community, a number of stable and symptomatic patients have declined for home-based care. This was evident from the fact that some patients were requesting to be dropped home by the vehicle other than the ambulance. They were saying, if my neighbors see that I'm being brought in an ambulance, then they will just run away from me. And there are others who are also requesting if they can be dropped 2 streets away from their residence, which again obviously was not acceptable. And all this was attributed due to stigma, because there is still a lot of misconception about this COVID-19 pandemic in the community. Human resource. So we also have to increase our employment or recruit additional, especially public health officers, to enable a swift follow-up of the patients on home-based care. Obviously, motivation of staff members like incentives is still missing. And then follow-up. Weekly testing is actually sometimes a challenge, because some patients do not cooperate. They will switch off their phones occasionally. And lately, we have had a profound shortage of testing kits at times, which has also made follow-up tests a very bumpy ride, to say but the least. Then the main challenge, which has recently cropped up, especially in Mombasa, we have seen this, the private hospital coordination with the Mombasa County Public Health Office. Most patients discharged from the private hospitals for home-based care are actually not on any follow-up, and they don't have any way of reporting if they do develop any symptoms or if they are to change condition. The public health office is also not informed. So there are a certain number of questions that we have put up, which we are still yet to answer from the private sector. So who verifies the homes if the home care, if the patients do meet the standards? Do they have a particular person, which we have seen they don't have actually anyone? How is the patient transported home? We have had reports of patients being told that you are asymptomatic and they're discharged home and they go with taxis, which is actually dangerous. Who follows up on the patient while the patient is at home? Is the public health office informed? So we have seen that the private sector actually does not coordinate with the Mombasa County Public Health Office, and this can actually become a very big challenge. And does the community health worker know about the patient? So lately we have seen that the public health office is trying to recruit even the community health workers. So so as to increase their workforce. So if this coordination is brought about, then the main challenge will have been overcome. But this is actually causing a break in the chain of follow-up of these patients. So I think that brings us to the end of this presentation. Thank you so much, and welcome to Mombasa.
Thank you. Thank you so much, Dr. Vavani. Thank you for that good presentation. Dr. Sud, you want to say something?
Well, thank you very much, Dr. Varvani. Dr. Varvani actually has been heading the home-based care, and it is not a simple thing, to tell you the truth. Those numbers, 107, I've seen a couple of questions asking, how do we monitor them? Now you can imagine we have to zone them into 10, 10, 10, so that every time we go to their houses every week, we go and sample 10 people at a time. Now, because the numbers are much more, so we have increased the pool up to 15. So we actually dedicate a team which goes up to the home and do all these tests while they're there, because you can imagine asking them to come all the way back to the hospital. We don't know the means which they are using. We have also involved the community health workers, which has made this very nice, because the community health workers are well known inside the community area. So sensitization also of the community in regards to stigma, and in case they have any issues, they could even get through the community health workers who actually get in touch with us. Since we started this, we have not experienced any of the patients who needed to be returned back to the hospital because they had changed from being mild to moderate or experienced other symptoms. In regard to the ambulance, a lot of people feel maybe we should use an ambulance which doesn't have any stickers, but I feel if we move towards that direction, we are just increasing the stigmatization. I mean, this is true. We are going to go with COVID all the way till the end of the year. And what we need is to sensitize people to accept that this is just another disease which people get better. And this is why the community health workers, we involve the chief, the religious areas, people also. There is a radio station here we have, it's called Radio Rahma. And you'll find even this Thursday, our chief for Mombasa County of Health is actually also going to give a talk, and mostly it's in Kiswahili because people tend to understand what the problems are going on. One of the challenges we have is actually having a designated team, which needs to consist of a lot of public health people inside that team. And the public health play a big role when it comes to home care. One of the questions always we get asked is, where do they masks? And I usually throw back the question and say, the healthcare workers who come from the hospital, when you go home, where do you throw yours? And you'll find actually the majority of healthcare workers don't even follow the protocols. For our patients, what we do is we give them either the bags or they take any plastic paper bag or any type of bag and put their masks. And when we go to do for them the routine swabbing, we actually collect those bags and go and incinerate them at our institute because we have an incinerator. But I wonder where the healthcare workers drop their masks also. I will leave that question there, and maybe we can take more questions if they are there.
Thank you, Dr. Sud. And actually, that's a challenge to all of us. Where do we put our masks at the end of the day? I must confess, I've not been following the protocols, but I hear you, Dr. Sud. I hear you. So as we ask about the patients on home-based care, let's also look at ourselves and are we doing the correct thing? So thank you, Dr. Sud and Dr. Vavani. Before we go to the Q&A session, human behavior is very complex. And the fact that the patient is already fearing that they don't want their neighbors to know that they are unwell, how are you ensuring that these patients actually adheres to the form that they signed, the regulations and the rules that have been put in place? How are you ensuring that they're not interacting with their neighbors? with their relatives. Probably their relatives might come to visit. And we know we all live in communities, and probably Mombasa is still the same setup as our other areas where you have your cousins will come, your grandchildren will come to visit you. How are we ensuring that the human behavior or the human nature is still being adhered to, that we are following the rules and guidelines even in our homes?
Yeah, I think that Dr. Varvani actually showed you that we actually do this self-declaration form. And actually, when we are actually talking on the self-declaration form, there is one of our psychologists actually, there are two of them, but they usually join to assess for us also in terms of the psychological aspect of these patients. Because if he tells us that he feels that the patient is not going to abide by, maybe he has so many deficiencies in terms of who will bring the food at home, who will make sure that all the essential things we are talking about, disinfection, we are talking about masks and everything, who will provide all this when they are home. And if we find that there is a problem, or the people who they are related who also don't understand what it entails, then we usually don't allow them to go. We actually have very strict criteria, and sometimes it gets us in trouble, but we stick by our guns, because they bypass and move to the higher authorities to say we have denied them. But then we also give our verdict and say we denied because of 1, 2, 3, and this is why we cannot allow. The issue of stigmatization is there, but as I'm talking to you, we are seeing people understanding this condition more. And we have seen now even reduction of people coming to visit people in the hospitals. And you know, the culture here is when you are sick, everyone flocks in the hospital. This has also been reduced. And the fact that we have community health workers who we alert and say we have bring in these patients here, and we need you to also communicate with them. And we have also in our team whose work is just to give a call early in the morning and find out, do you have any temperature? Is everything okay? Are you having any deficiencies which you need us to help you? And that's how we are doing it.
Thank you for that, Dr. Sud. To the participants in this forum, there's a slide Dr. Vavani shared, the last slide, about private hospital coordination together with the county. Kindly give us suggestions in the Q&A section how we can make this better, because I know it is a problem that will cut across all the counties, including Nairobi County. When a patient is in private facility, who follows them up? Are they registered under the county system, or what? How best can we capture this data, and how best can we create mechanisms of following up the patient? So please put your suggestions in the Q&A section. I'm sure the team from Mombasa will be able to see it, and team from all the other counties. And also we have Dr. Maritim, who's here with us, and she'll be able to see it, and the rest of the team that is very instrumental in developing the guidelines for home-based care or patient care during this time.
Yeah.
So let me quickly go through the Q&A. Francis, I believe your question about challenges has been addressed. You asked your question before the presentation started. So if there's any particular challenge that Dr. Vavani has mentioned that you'd like to be expounded, you can re-ask it again, but I believe your question was answered by Dr. Vavani during his presentation, including the achievements. That so far, they've had 54 male patients, 50 female patients. The patients have been recovering a bit faster in the home environment, probably due to the social support that is there, I don't know, but they've had their challenges and their achievements, and your question was already addressed. So Dr. Vavani.
Yes, Doctor.
Are you providing any materials for protection for the guardian, the person who's taking care of the patient? Are you giving them the gloves? Are you giving them PPE? Maybe an apron if it's available? Are we giving them anything? Plus also the disinfection, how are we Are we educating them on how to wash the patient's utensils, clean the patient's room? Are we putting those things into place?
Yeah, okay. So that's a very important question, and thank you for raising that question. Now, let me try and briefly explain how our home-based care works. So we identify the patients who have actually fulfilled the criteria for home-based care. So that is day one. Once we identify these patients, we take the contacts of the next of kin who they are actually staying with, who reside together in the residences, and we also take their area where they stay. As Dr. Sood says, then we zone the areas, so that information is then given to a public health office. Now, on the second day, the public health office actually visits each and every area of residence of each and every of the patient, and one by one, they actually go and check before they take the patient out of the facility. They ensure that the facility or the home or the residence actually meets the checklist. Now, one of the important things in the checklist is the availability of water, the room, disinfection, and prevention of or contamination prevention. So the public health officer actually interviews the people living with the patient before even bringing the patient home, and makes sure that these things are available. We have had an instance where like three of the families requested to be supported, and our public health officer actually did provide the necessary support through the institution. Another thing that the public health office has actually done was to actually explain to them about disinfection and how to use how to make up the disinfecting material and how to even use it up. uh, One thing, in fact, from that particular exercise, what even cropped up, and Dr. Sood will tell you that we are even thinking of putting up a research about that, is to look at the knowledge, attitude, and practice with an intervention that we are already doing, uh, of educating the household members and the patient as well. So are the knowledge, attitude, and practice changing after the interventions? So I don't know. I hope I have answered part of the question.
Yes, you have. Yes, you have. And thank you for explaining the process further. There's a question about testing. And somebody is worried that as much as we are saying stigma is a challenge, when the public health or when the lab test, the people from lab come to collect sample, somebody is asking where do they don and doff? And number two, somebody is also asking whether there's confidentiality. Do we ensure that we have confidentiality during these home visits by the public health officers when they're doing the follow-up process? So those are some of the things that probably might be causing the stigma. So if you put measures to address them, we'll be glad to know or to understand better your system.
So we have thought about that. We have thought about that. And so we came up with a solution for that. And the solution is there are different types of patients we actually send on home-based care. Now, there are people who live in their own houses, which have their own borders, fence, and everything. Those are very simple ones to deal with. And then there are people who actually live in flats or areas where there are so many people inside there. And what we do for them is we have a designated ambulance for them again. They are usually brought in to the hospital in that ambulance, and we actually test them. If we see also there is the factor of stigma, we actually do the collection. We have a team which goes even in the evening to these houses, which actually collects, because most of the tests are done the following day. So the stigma is there, but shy of and say that we need to hide everything we are doing, then we are not bringing out the message out. I remember very well when we started with COVID, the first thing we were being told is doctors are not dying. So is it true that other doctors are dying in Europe while in Kenya we see 0 deaths? And if you have such an attitude, really, I mean, people must see that this is what is going on. We have on board our psychologists who continue the psychological therapy for these patients, even while they are outside. Even the ones who have turned negative, we still follow them up to find out how are they integrating back. And if they give us a go ahead and say, now they're back to normal and they appreciate everything, we back off from there.
Thank you, Dr. Sood. Thank you so much for your response. I've seen there are a few suggestions from Maurice. Is saying the county must coordinate the COVID-19 response with both public and private health facilities. This will streamline the response and mitigate measures. Also from Vincent, he's saying follow up on patients from private hospital, involve the mental health team as early as possible. I suggest once a patient is diagnosed positive, let the patient be aware that it is a policy for them to be followed up by the public health officer at home. From Dr. Joy Mugambi, she's saying it is also important that the county finds a way to offer incentives, such as certificate and awards for the private hospitals that meet the laid down criteria. From Christine Sadia, she's saying the private sector in Liberia during Ebola reported to a central office of case management team, or if they have met all the parameters, the linkage and placement is done centrally. So those are some of the suggestions, Dr. Vavani and Dr. Sood, that are coming from the participants in the section, in this session, and we're learning from them. I like the idea about a central office of case management where both the private and public facilities report there. About the incentives, I don't know, maybe the county can advise on that, whether it is possible to actually incentivize people to do the right thing, because this is a government policy.
Actually,
so, yes.
So we have tried to see how we can integrate the private hospitals, but there are some challenges. Number one, which we have already rectified that challenge, was a lot of private hospitals now are currently doing their own testings. So they are only obliged to report to the national, and we didn't have any information at the level of Mombasa County. So now we have integrated that system that all the cases we have to be informed. And once we have done that, then we are moving in phase 2. And phase 2 is we need to find out if they can come up with their own home-based care surveillance team with our support from public health office, because the public health office is overwhelmed actually. So what we have done is the hospital itself has employed people, not from Mombasa County, but a hospital itself has employed people to facilitate this. So when we go back to Mombasa County, providing each and everything for the private hospitals, it will not be realistic, but we can partner with them if they come out and tell us, okay, this is what we have and this is what we can do. That's what we'll do for them. Because currently the private hospitals are actually testing all their health workers. But in case a health worker's family is positive also, we are the ones who will test the family, because they are only testing their health. So there is a lot which we need to share, and we will learn. And I hope in the coming few weeks, we are trying also to organize a few meetings with them and see how we can integrate this so that we can have a best way with home-based care.
That's true. Thank you for that. And it's true, the county might not be in a position to do everything for the private sector. So the private sector, it would be best if we also look for ways of working together with the county. There's a request from Dr. Fuhad, and he's saying Bamburi Cement is organizing 2 of our guest houses to cater for home-based care in case of positive cases of our employees. Is it possible to get the team to come and inspect and give us feedback? Dr. Vavani, I will not let you answer that, but Dr. Fuad, Dr. Sood, Dr. Vavani are here. Kindly create linkage with them, and I'm sure they can be able to help you out in that aspect. But that's a good example of a private facility or a government facility, another facility reaching out to the team. It must be a bit strenuous for Dr. Sood and his team to go to every facility and find out. But if you reach out to them, probably they might be in a position to assist you. So before we go to the participants who've raised their hands, there's a comment from Bernard Ongucha, and I'd like to ask Dr. Vavani to clarify on this. And he's saying, thank you to Mombasa team. I would like to get clarification about the zoning of areas for follow-up. You talked of 10 to 15 people. So does this mean that they come together at one place, or the team does the visit in all the homes within that zone? How do you do it?
Thank you, Dr. Rhoda. To respond to Bernard, well, the zoning we are talking about is, you see, Mombasa has, you can divide Mombasa into areas, yeah? So the zoning we are talking about is actually for follow-up, mainly for follow-up of these patients. Now, if you see, if you don't create zones and assign every zone to a particular person, then you will create a lot of chaos, because you are following up a patient from different particular places. But if you know that your follow-up is based in a particular zone or in a particular area, then all patients who are actually discharged home for home-based care, from the database, you know how many patients you're supposed to follow up. Now, again, from this particular zone, you, as Dr. Sood clearly explained initially, follow-up testing is devised in such a way that for those who are living in their own gated estate or in their own compound, where stigma is not really an issue per se, then they can, the public health office can send their guys there for the repeat testing and follow-up and the necessary support. For those who are living quite close, then we have scheduled follow-up such a way that one of our ambulances actually goes to pick these patients and brings them to our facility for testing. So this is the approach that we have so far been using. We had started with zoning with 10 patients per zone, but as our numbers are increasing and as our human resource from the public health office is not increasing in a matched proportion, then we have had to increase the number of people in a particular zone to 15 patients.
Thank you for that. And I hope you have more staff on your end, because as more patients are going on to home-based care, as you've said, we'll need more people to also relieve the ones who've already been doing it. And 15 sorry for that. 15 homestead is quite a big number to be able to be handled by one person. Dr. Wambani, would you like to say something?
Thank you very much for that presentation. It was very informative and very nice things that they are doing at in Mombasa. Now, I have two comments and a suggestion. First of all, my comment is that they've done a very good work in Mombasa. That's from their presentation. Somebody asked a question about movement when they're in home quarantine, self-quarantining at home, home-based care. I would suggest that first of all, we involve the local administration of all cases that have been reported within the county, and which ones are positive, but they've been allowed home-based care, that once they are registered, there should be a way of limiting their movements. And in that way, because they all have phones, probably we could ask them to do online shopping for whatever they need, and the homeline deliveries from whatever they want, in case, because most people go out to shop for food and so on. So could we devise, put into those guidelines that they will be requested to have online shopping or online food, which they can actually request that would like such and such a thing to be delivered, so that you limit the movement from that home. And if you are making everybody in that home stay at home for the sake of the neighbors and so on, they should we should forget about this stigma thing, because we should send messages out. I'm glad they talked about radio and so on, that you can also be the next victim. So don't think that you are not a victim. So they should not be stigmatizing their neighbors. They should at least stay, keep distance.
Thank you, Dr. Wambani.
Thank you.
And yes, and I don't know how feasible online shopping is for the rest of Kenya. Probably in the urban areas, it might be within reach in Nairobi, maybe some areas of Mombasa, but out there at the other counties, I really don't know. But I'd love to hear from people who are listening from Northeastern, from Eastern, from Central. Is it possible? So
But
thank you, Dr.
One of the requirements was that they must have a phone.
Yes. Thank you. Thank you for that. Comment. Jonathan Mwangi or Athanasio Kotonya, unmute yourself and share your comment.
Thank you. This is Jonathan Mwangi. Thank you very much to the Mombasa team for the good work you continue to do. I have 3 questions. One, just to provide some clarity on the process flow in terms of who is eligible for home-based isolation and care, and when do they join? Is it newly diagnosed individuals, or are these individuals who've been with you in isolation at the facility, and then maybe you decide to discharge them for follow-up through home-based care? Maybe just that clarity. Related to that is how long they remain under home-based care and isolation before you eventually discharge them. My third question is for the patients that you've rightly mentioned that might not live in their own compound. Perhaps they have shared utilities, maybe in a flat or in the communal Swahili housing. Has there been proposals by the community on community isolation units or such similar engagements, and how has that conversation taken place? And also closely related to that, as we do the follow-up home visits, in your own assessment, how is the adherence to infection prevention? Because I know this was among key concern at home. Are the people and the caregivers adhering to infection prevention? And my last point, as you track the patients, there's provision for the Jitenge app being very useful to help you track, because the patients and home care can enter their daily readings, and at the EOC you can monitor who has checked in and whose symptoms have changed that you might perhaps need to quickly respond to, and who you need to discharge. So maybe as a follow-up, we can see how we can follow up to see whether that would be a suitable app for you to use to help you monitor. So thank you very much, and good work that you continue to do. Thank you.
Thank you, Jonathan. Before I let the team from Mombasa, Dr. Sud and Dr. Vavani respond, Jonathan, I'd like to just ask, have you used the Jitenge app? I've not used it, but Dr. Agatha Olago did a good presentation. And if you're in a position to tell us whether we've had anybody from Nairobi using it or from any other of the counties use it, we would also appreciate, so that we know that it's being used. So Jonathan, are you in a position to know whether the app is in use?
So the app currently was mainly geared towards patients in quarantine. It was being used mainly for truck drivers. As home-based care has come in, it's been repurposed to also take care of patients under home-based care. So in terms of patients who are currently using it for home-based care, I'm not sure we have any, but we'll be able to quickly find out. But I think it's been used, for tracking truck drivers and making sure they are, under quarantine and they can be monitored well.
Okay, thank you. Thank you for that feedback. Dr. Sud, Dr. Vavani?
Yeah.
Yes.
So these 2 weeks, actually, we have been having trainings on the Jitenge app. And we are hoping actually more people will be trained on this. and then it will be actually something very nice. I have seen the G10. It will help a lot in home-based care. So we are actually training people now. In terms of who is eligible, is it a person who is in isolation or newly diagnosed? We have both categories actually. There are people who we have isolated initially, and they have taken time to seroconvert for one reason or another, but then they meet the criteria of meeting home-based care. And we actually transfer them to the home after inspection with everything. And one of the things I think Dr. Barbani was trying to tell you is we give you a list of what is required to be in that house, because like if you have your utensils, they need to be dropped in a bucket of chlorinated water, or jik in short. So you have to, by the time the public health comes to your house for second inspection, they have to see everything is there before we allow it. There are people who are already at home and they came to do the test either in government facility or private facility. And when the results come out, we trace them where they live. And if we find out that where they live, they actually, their houses meet the criteria, we don't bring them out from there because a lot of them are symptomatic, but we just monitor and give them the guidelines which they are supposed to follow. And it's very clear. If you step out of the guidelines which you are supposed to follow, we return you back. And this has actually helped, because you can see there is something we are trying to ascertain. Is it that people, when they went home,
Sorry about that.
Okay. There is something which came out in the presentation, and we need to look at it. The patients who are in isolation, it is a stressful.
From the group.
Okay. The patients who are isolated, they are actually inside a stressful environment, and possibly that stressful environment actually interferes even with their immunity level. Because once you send them inside an environment which they are comfortable with, we are seeing, I mean, it's not easy for patients we just isolated outside. Within a week or so, 35 are turning negative. So there is a correlation between that. We have formed a couple of teams with our young doctors there, and we are working on a lot of research papers, small things to look at into all these aspects. So that is one of the things. How long home-based care? Oh yes, the criteria is the same, whether you are in isolation or home-based care. You need to get the negatives, and once you get the negatives, then we tell you that now it is safer. You can stay for another 7 days and you can continue with whatever you are actually doing. Community isolation has been brought up on the plate, and it's something which we can help, especially for people who do not meet the criteria. Now, there are people who are staying in areas like Mvita where there was lockdown. You will find the houses, people can stay maybe 3, 4, 5 houses, but they share a toilet, which is out of the way for home-based care. But if there is a community area which can come up where these patients can actually be inside their own isolation inside the community where things will be better for them, then it is something. I think even the doctor who was asking about Bamburi cement, this is one of the things which they have proposed, but we are yet to finalize and see if it will work. But it's something which is there. In terms of infection prevention, we make sure they adhere to infection prevention, because the people who do these rounds there, they are public health officers. And if we need to help in terms of anything, we usually also assist.
Thank you, Dr. Sood, for that response. And just a few comments about public and private. Rogers is saying public and private facilities should work together in case of home-based care. In this case, the private facility should be reporting to the county management committee as scheduled. There's another feedback from Isabel who's saying support a central county coordinating team for both public and private hospital. There's a comment from Dr. Okemwa about the online shopping. He's saying in Turkana, online shopping cannot work, although arrangements can be done locally with identified vendors and suppliers. Dr. Sood and Dr. Vavani, my question is on cost. I've seen quite a number of people asking whether NHIF is catering for this home-based care, because it's a service that you're rendering. Actually, you're rendering for almost 2 to 3 weeks, and it's continuous, and I'm sure it's very tasking. So there's a question about who's catering for the cost of PPE, and also is NHIF paying for home-based care?
Yeah, I think first I'll leave Vani to actually brief you, because they disturb him on these questions always inside their isolation.
Thank you so much for this question. Well, the cost implication is two ways. I know the question specifically is for home-based care, but there's also the implication when the patient is admitted in the isolation unit. Yes, we have had quite a lot of issues because it was publicized once upon a time that treatment is going to be free. However, we have not seen any solid evidence like a memo or a letter to any particular hospital that this treatment is supposed to be free. So that's still a gray zone, and usually it's beyond us to respond to the patients. Yes, NHIF, from our side, like our hospital, those who have NHIF, it's not been a very big issue. Initially, it was a big task, but I think through the efforts of our Chief Executive Officer of the hospital, Dr. Kandwala, and the senior colleagues like Dr. Sood, who were always by his side, we had a meeting with the NHIF guys, and it was sorted out. As regards the cost for home-based care, well, we can't really charge. We are not actually charging, though in essence, there is a cost implication, as you rightly said, because there are PPEs being used, there is fuel of the vehicles to and fro, and there's also extra support, and then there's a lot of human resource that is put to that task. So really, we have not yet come up with a model of maybe charging or putting a cost to that for the particular patients. That's what I can say from my side. Maybe Dr. Sood would want to enlighten us more.
Yeah, thank you, Dr. Barbani. I think you captured it the way I would have said it. One of the challenges we are looking at way ahead is the cost implication of home-based care. As per now, we are trying as much as possible to see how we can assist. There are a lot of patients who have been admitted of the fact that they believe that it is a free treatment, and some don't even have an HIF. So we have a waiver committee which sits down and just evaluates within 6 hours to just allow them to go home. So the burden is there. The reality of how we are going to support this if it continues longer, that is a big question.
Thank you. That's true. It's probably an expense. It's very expensive. And how do we support it if this continues longer? That's a question that I hope we'll be able to address, maybe from the ministry level at some point. But right now, I'd love to hear from Dr. Maritim. I don't know whether, Dr. Maritim, how are you?
Let me just walk out. I'm in a meeting, but let me just. Thank you so much, Rhoda,
Yes.
and the team, and thank you so much, Dr. Vavani and Dr. Sood, for an excellent job that you're doing in Mombasa. We are always learning from the Mombasa team because you're way ahead of us. So my comments are just very few because it's different to sit and write the guidelines or be part of a guideline development committee, but to see the guidelines being implemented then is another story. And we are really grateful for Mombasa. I was really looking forward to this session to learn from what you're doing. And really listening to your experience, you're doing a wonderful job. And it will even help us as we think of training the rest of the country and implementing the guidelines, because you've gone ahead of most people and you're already implementing the guidelines. You can already know what works and what needs to be strengthened. So a few comments is about the resource required in terms of implementing the guidelines. And you've clearly said it, there's a lot of human resource that you, even as a hospital, have done, like, to meet the gap. That's not a county responsibility, but you've taken it upon yourselves as Coast General Hospital. So looking at it, Dr. Jonathan Mwangi has talked about the app, and we are hoping that even as you implement the app, it will maybe make your work easier, because the Jitenge app is supposed to sort of empower the patient to take their own self-measurements, record their signs, not really signs, their symptoms that they may be developing, and feed it on the app, and there's a 2-hourly reminder. And all this information is relayed centrally. So we're hoping that the data that's generated from the Jitenge app will be available for you to see within your area, and also will be available at the national level through the Emergency Operation Center, EOC. So it will probably make your work easier in terms of monitoring the people. And we really hope that as we implement the home-based isolation, it's an opportunity to empower our patients. Many people are asking about the required PPE for the household. When you look at it, these people are largely asymptomatic and mildly symptomatic. And these are the same people we've seen in the videos doing the rounds on social media, like in KU, they're dancing, they're enjoying themselves. So it's really to empower them to take care of themselves, look at the symptoms they're developing and record them. So they are not people who are debilitated, they're not very sick people who you have to go and nurse, do 2-hourly turning. So they are less resource intense. And the PPE we are talking about is the things, if somebody has to enter that room where the person is being nursed, then the precautions that they have to take. And then even while inside there, the patient then has to have a face mask. So in terms of the resource requirement, we're not talking about a hazmat suit, goggles, face shield. It's not the same level of intensity of PPE that we see in the isolation unit, but it's to a lesser level where you've empowered the patient. You give them a disinfectant to disinfect the surfaces in the room where they are. They can clean their own room, so you don't need a lot of people going inside there to do additional nursing care, other than just to take food to the patient in that room and then come out and with the utensils that have already been dipped in a bucket. Understand for all of us. So I think really we're grateful to Mombasa. You are setting the pace for many of us who are coming behind you. And I know on this webinar, we have very many counties that are logged in to really see how to implement and what will work in their setting. Even Nairobi County is also listening in to see what would work in Nairobi, because Nairobi probably is different from Mombasa. It has a larger geographic region. We don't even know how we'd zone Nairobi so that we're able to visit people and do what Mombasa really is doing. But we hope that the Jitenge app will, in addition, help us to be able to monitor the patients. But thank you so much, Mombasa. You've also talked of applying the Jitenge app. So we are hoping that once you do that, you can even share with us through this forum your experience, and you can really learn from you. We also have noted your challenges, and we'll see how even at the national level, we can try to see how to strengthen what you're currently doing. Let me stop there. Thank you.
Thank you, Dr. Maritim. And more specifically, the challenge about the private hospital and the coordination, that would be a very good area and gray area, which I'm sure most counties will encounter. So if it can be addressed from the national level or from the guideline perspective, that would be very good.
Let me talk about it, Rhoda. Sorry,
yes.
Let me mention about that. So I think
yes.
What I'd like to say, and I think this really is the position of the ministry, this is a public health response, and the public good has to override everything else. And really what this means is that the county, the public health system at the county has to take that responsibility of ensuring and sort of setting the tone that whatever the private sector do has to conform with the Ministry of Health directives. So maybe to summarize is that the county public health department has to supervise even the private settings. And we saw this recently over the weekend in Nairobi when we've had the outbreak
Let me finish this webinar.
In Shalom Hospital. So the county, please take care of all the hospitals that are within your jurisdiction, both the public and the private hospitals.
Thank you, Dr. Maritim, and I agree the county should take care of both the counties, but of all the facilities. And I hope we will not see unfortunate events like the news that we saw about Shalom. We will not close facilities, but we will empower them and strengthen them. There's a question from Amina from Isiolo County, and she's asking for contacts for the person who's handling the Jitenge application. So she's saying we're looking to test Jitenge application for purposes of training of our community health volunteers. Kindly share contact of the relevant focal person. If there's anyone in the group or in this session who knows the contact for, if you have contacts for Isiolo County, somebody who's or from the ministry level, please share the contact so that the other participants can also see who to contact in case of Jitenge, in case they want to roll out Jitenge app in their counties. Thank you. Yes, you'll get the slides once we get approval from Dr. Sood and Dr. Vavani. But what the questions and answers that they've answered have actually been, they've had more information. Dr. Onyancha. Hello, Dr. Onyancha.
Yes, Dr. Claude, how are you?
I'm very fine.
I have become, I think, a constant, like I'm a member of Kenage, but I love
Karibu. Karibu.
This is really a topic I wanted to start from the beginning, but I think I came midway. However, I've listened to the discussions. I just wanted to make one comment that unfortunately, home-based care is the way to go, whether we get it right or wrong. And I'm happy that Mombasa, as Dr. Maribeth has said, is that they are ahead of us and we are learning. We don't have to reinvent the wheel. But basically, I think if we can be able to really emphasize the issue of asymptomatic patients and the fact that from what evidence is showing that 88% actually are asymptomatic, these are the people who are going around their business, and therefore isolation is just to keep others safe, and therefore they should not be like when they are going home, they are going to sleep or whatever, they should continue exercising and doing everything. If it's a place they are staying, they should be able to do their laundry, they should be able to clean the place they are staying, and then they will be able to go the ones to actually make sure that the people around them are safe. What we need is that we have developed guidelines as the clinical team have said, but these guidelines must be able to be understood, and people must have this perspective that this is for my own good. You see, the way we are putting on masks because the police might arrest us, unless we change that mentality that even home-based care is not really a punishment, it's not anything that we are risking the community. Once they impress, that's one I think will go ahead. I remember the quarantine. I had a very bad experience with that compulsory quarantine, where people think that they are doing you a favor by being quarantined, but not seeing that they are doing themselves a favor. So one of the things that we have to do is actually a lot of awareness creation and really looking at the advantage and the advantages of home-based care. As somebody has said that, in fact, when you are isolated in facilities, it is more stressful than when you are isolated within the community. And once the community embraces you, I think it will be easier for the two, for the people, for the family, and even the person who is unwell. I'm happy. I will be joining your webinars and not necessarily commenting, but I just felt that it's good to comment that the people in isolation in home-based care are not doing anybody a favor, but they should see it as actually a responsibility for them to support and take on ownership of their health issues than thinking that everything, the solution is in the hospital or isolation facilities. Thank you. Over to you.
Thank you, Dr. Onyancha, and I agree with you. We should look at this as personal responsibility, and we're doing individual public good, not an individual agenda. We're not doing the government a favor by embracing home-based care. And I also agree with you, the patient is actually, yes, let me call this person the patient. The patient is actually not sick, they're symptomatic. It's just a not to embrace the sick role fully, but to also continue doing some of the activities for themselves. Dr. So there's a question from Dr. Mugambe, and she's asking about healthcare workers.
Yes, sir.
Yes.
So, in fact, this is a topic which this coming 2 weeks, I've just focused on this because we are seeing a lot of healthcare workers actually now, because of some are community transmitted, some actually get it from the hospitals. The criteria is the same. We come to assess your home, and if it meets the criteria, we allow you to be handled as a home-based care. If you do not meet, we have a facility which is specifically for healthcare workers, and we take any healthcare worker from any facility. It doesn't matter whether you're in private or you're in government. If you are sick and you need to be because of oxygen, we actually take you in our facility and we look after you till you get well. We had them from a private facility who we have treated and discharged, and currently we have 2 staying with us from a different facility. But if you meet the same criteria of asymptomatic, your household is can meet the criteria of home-based care, we allow you to stay home.
So Dr. Mugambi, I hope your question has been addressed. This time the rules apply to both sides. We are, as much as we're the ones implementing the rules, we are also part to also get the same restrictions. So if we meet the case scenarios, or we meet the case and the checklist is ticked and we have the infrastructure, the accessibility, the accommodation, the resources, and people at risk at home are protected, then home-based care for the healthcare worker would be advisable. But if we are putting our own relatives at risk, it's best if we stay at the hospital. There's a suggestion from somebody that all estates or villages or leaders should notify the neighborhood of a case so everyone can be cautious. As much as you're trying to demystify the stigma or demystify the disease, I still think this will be a bit reckless for the healthcare worker or the public health officer to do that. Confidentiality comes first, patient confidentiality. So going around informing the Nyumba Kumi leader or the chief that somebody in house this and this or in this block has been confirmed positive, that would be very reckless from our end, but I'd love to hear your views. But I think that will be a bit reckless from our end, as healthcare workers were supposed to be giving the support to the patients and their relatives. Dr. Vavani, there's a question about home deaths. Have you had any reported home deaths or any reinfection? The patients who've embraced home-based care, or who you put on home-based care, is there anyone who's tested negative and then gotten reinfected in the process? Or have you had instances where their relatives have been infected as a result of this patient being at home?
Thank you, Dr. Rhoda. Fortunately enough, so far we have not had any such case where a patient discharged home on home-based care has either deteriorated or passed on, or maybe in the unfortunate event due to the interaction with the household members, probably another household member has tested positive, or even a household member becoming symptomatic. So far we have not had any such scenarios, and that I will largely attribute to the fact that when the public health officers go to review the patients, there is re-education. It's not just about going to swab the patient and coming out. there is re-education both to the patient and to the household members. And then there are those people who are continuously calling these patients or the household members just to inquire and ask if everything is okay and if there's any issue. So far we have not had any such eventuality, and we can thank God for that.
Thank you.
Yeah, in fact, you will be surprised. A lot of our hotline numbers are being called by healthcare workers asking, is it siku kumi ama siku kumi na nne? And you can actually appreciate that they are the ones we need, but more cautiously when we do home-based care than the patients, because they understand the implications, but at the same time they doubt the number of days. So these are some of the things we are experiencing.
Okay, I know part of your criteria or part of the checklist was accommodation and resources.
Yes.
And I'm seeing quite a few people asking about whether the county is providing food, rent, and upkeep money for people at home. So is the county government able to support? Yes.
No. So this is why we are actually saying there are 2 inspections done, and the first inspection is just to look at the location and how the household is. And the second inspection is to look if you can afford to have your own box of masks, if you can afford to buy jig for your disinfection. These are some of the things we actually look at. And if you can't, then you'll have to stay with us. So there are some people who meet the criteria of going home, but they fail on one particular thing. And I'll give you a simple example of currently we have 3 patients who are asymptomatic, but they are on dialysis. Now, there is a challenge because they are doing twice weekly dialysis, and how will they come in and out of the area? So the best thing is for us to just stay with them and they continue with their dialysis till they finish, because it's the implication of cost. It's the implication of cost for them. So the county is actually pushed to the brim, and I don't think so they will be able to afford anything like rent and the rest of the things.
Thank you. And I agree the county might not be able to provide all that, but there's a very interesting question from Moses Mwenda about psychosocial support. Are we providing psychosocial support for patients on home-based care, either through online forums or face-to-face sessions?
Yes. Yeah, so this actually is what I said. We have 2 psychologists who keep on follow-up through our lines. And what we have realized, the psychologists play a very important role, not only for the mental and psychological support, but they have developed a kind of understanding that sometimes they do not tell us things, but they will report to the psychologists that this is what they are experiencing and what is making them not feel better, or what we should do for them better. So we get a lot of feedback from the psychologists. When we have meetings, we get a lot of feedback from them. And it is actually true. The psychologists have to be not only for the patients, but also for the healthcare workers who are moving around. Sometimes they finish these rounds at around 8 p.m. and they have to go home very late. So we have had a couple of meetings where we had a psychotherapy sessions, and I usually sit in whenever they are having, so that we can discuss together and all of us talk and see how we can help each other. So it's very important, I agree.
Thank you. Dr. Vavani, part of the people you mentioned were at risk, especially at home, were children less than 2 years. And there's a question from Dr. Mary Nzani and Faith Mutaura. And they're asking, do you have any children on home-based follow-up? And if the mother is positive and the child is negative, how is that situation working out for you? And also, what challenges are you faced with children on home-based care, if there are any on that follow-up?
Thank you so much, Dr. for that question. This is a question that we have faced repeatedly. So I will answer it. Sorry. Okay, yeah, I will answer it in stages. So one, yes, we do have children as part of patients on home-based care, and some have also already started turning negative, which is a good thing. The second stage, what do you do when you have a child who is negative, but the mother is has tested positive? Uh, Now remember one thing, especially if this child is on breast milk or is being exclusively breastfed, there is from time immemorial we have been told that there is a right of the child that no one can actually take away. So yes, this question has come up severally, and it was very clearly demystified by Dr. Sood just last week. I remember that the mother has to be taught about hygiene. Uh, she will only take the child when the child is to be breastfed. So before touching the child, the mother will obviously observe hand hygiene, will have put on the necessary protection, that is a face mask. Uh, and then before putting the baby to the breast for the latching, will actually have to clean the breast as well, and then the baby will be allowed to breastfeed. After that, she can put the baby back to the position, and then again clean post touching the baby. So at least that way you will have made sure that the child gets his or her right, and the mother actually has maintained high IPC standards to prevent contamination or cross-infecting the baby as well.
Thank you. Thank you for that. From Jean Gitao, she's saying patient confidentiality is extremely important. However, this does not apply to notifiable disease, especially those classified as novel pandemics. The protection of the health population is of key importance. Thank you, Jean, for that comment. Thank you. Dr. Ogutu from Kemri, I can see you'd like to make a comment. As we wait for Dr. Ogutu, maybe Professor Anzala, would you like to say something?
Yes, I think, do I go ahead or I wait for Dr. Gutu?
No, go ahead, go ahead.
Yes, Dr. Sood and your team in Mombasa, I think this is great. Congratulations. We've been looking forward to this discussion because home isolation and community isolation is going to be key. And I think you have led the way. Mine is just to say continue. Let's say focused. I think that's all that I can say now. And let the other teams, the other counties that are thinking the same, do exactly what you have said. And what I take from you is clear that counties will have to also zone themselves, maybe sub-counties or even go lower to ensure that the human resource is given allocation to be able to manage. So for me, it's just to congratulate you and your team on the good work you're doing. Thank you very much.
Thank you very much, Prof. Thank you.
Thank you. Dr. Ogutu? Hello? Okay, so as we wait for Veronica Manduku to look for Dr. Ogutu. Hello? Okay. So as we wait to get Dr. Ogutu online, I see you wanted to make a comment. We will. So there's a lot of appreciation for the team. Thank you so much, Dr. Bhavani. Thank you, Dr. Sood, for that wonderful presentation and for actually talking to us step by step once you translate a policy or a guideline to actual work, then you understand what goes into it. The document looks very simple, and from the way Dr. Olago presented it to us, it looked simple. But as you implement it, as Mombasa County explains the experience, we're also learning a lot. So thank you for that. Let me see whether Dr. Gutu is available before we end the session. There's a comment from Dr. Anthony Wanyoro, and he's saying home-based care for all patients, whether from public or private institution, should be coordinated by one team, including follow-up and transport. We should pool resources such as public health officers and ambulances. From Dr. Onyancha, she's saying, while a breastfeeding mother is positive, she'll stay with the child only when breastfeeding. They must put on a mask and practice IPC standards. All right, so my take home or my key pointers from Dr. Vavani's presentation and Dr. Sood is, one, we have to have teamwork, and it has to be a multidisciplinary approach. You cannot do it as just the doctors or the nurses or the public health. Everybody in the healthcare system or in the healthcare food chain has to be involved in this. Then the public health officer plays the most vital role of confirming the residents, the checklist, the environmental checklist from the ministry. We will share that with you. I've seen there's a request from Dr. Richard Kamau about if we can share the environmental checklist. We will share with you. So the public health officers has the key role of confirming, and actually I think they're the most, they're very important. Apart from them, also the doctors to say whether the patient fits the criteria, is eligible for home-based care. Then we have to develop a self-isolation declaration form. It might vary from county to county, depending on the cultural practices. I've seen somebody has brought up issues of African culture. That's Isabel. She's brought up the issue of culture. So you might, depending on your culture, you might decide to tweak it a bit, but the patient has to agree to adhere to the rules and regulations, and they should be well explained to them. So information is very crucial for the success of home-based care. Then transport is also an aspect that we need to look at, a designated vehicle to transport the patient home. Develop a channel of communication for the patient. The patient should be able to access care even while at home. So for Mombasa County, we see there are the 2 phone numbers which are manned by the team on duty, which is a good thing. And it's something that can easily be adopted by the counties and also any facility. And then follow-up processes for the patient, where the patient reports any symptoms to the hotline number. The public health officers, the scheduled weekly visits, and issue of testing should also be looked into. There's a comment, I've just seen a comment from Dr. Richard Aya. He's asking about funding. And as Dr. Sood has said, is that funding is a big challenge. NHIF, you're asking whether NHIF has played a role. Yes, that question was already addressed by Dr. Vavani and Dr. Sood earlier on. From Dr. Mugambi, Joy Mugambi, she's saying for health workers, psychosocial support, the KMA NNAK call center toll-free number is 0800-720-608. Please call in for help. So there's a psychosocial support for the healthcare workers that was officially launched, I think last week by KMA. That is their number. In the Q&A section, you'll find their number. So call in for help. Maybe Dr. Mugambi will call you for one session to tell us what kind of help you're offering, whether it's just psychosocial or there's more in terms of advice on how best to handle some of the situations that the county teams will come across. We also learned from the Mombasa team that we need to introduce issues of zoning. For it to be a success, you have to group the areas or the patients and know how best to handle them. And then also investment in human resource is very key, because if you have a team that is going to go around and you can hear they're working up to as late as 8 p.m., this team must really be exhausted. And you see, when you're going to see this patient, it's not a simple thing like dropping off a parcel. No, you're actually going to interact with a human being, and there's a processes that it can be a bit tasking, and it can take a toll on the healthcare workers. So we need to invest in human resource. Dr. Ogutu, would you like to make a comment? Hello, Dr. Ogutu. Okay. Dr. Sood, any parting shots before we end today's session?
I think this has been a very nice session, and we actually are happy that we are doing okay and we are ready to assist each and everyone. And I also want to thank my team, which is led by Dr. Varvani. You can see when you have a strong we meet on Saturday in the mornings, till afternoon, and we just strategize how to win this battle. And we are happy always whenever we succeed. So I want to tell everyone that the only way out is to have good teamwork, and just come up with ideas which suits your environment, and we'll always succeed. Thank you very much.
Thank you. Dr. Varvani?
Well, thank you so much for this opportunity to share my experiences. Yes, teamwork always wins, and this is, I guess, the future of healthcare practice. Where there's good teamwork, there's gonna be very good results. There's just something that I've noticed from the residents of Mombasa County. And I actually think that that's a good thing. I probably want to share the experiences that I've seen, or the way people have reacted. I mean, there was a lockdown, there was a curfew, people are losing jobs, it was becoming hard, economical times were bad. But it's the one who actually makes it out the best is that person who actually turns a negative into a positive. So of late, we have seen youngsters who have come up with very simple business ideas. For example, delivery. They have just taken a tuk-tuk or a motorbike, or two tuk-tuks and two motorbikes, and what they do is simply form companies that are going to be delivering stuff to you. So you order and you call them that I need this and this, and they deliver to your doorstep. So this has actually, like someone was asking about online shopping, this has actually improved these things, and it has made it possible for some of the patients to stay at home during this time. And remember, the first thing that the world said was stay home. So this has actually made it possible. So it's all about turning the negatives into the positives, and we shall win this battle at the end.
Thank you, Dr. Varvani, for that. And I agree, turn the negative to the positive. And I think Mombasa County costs is coming out very clearly. I think also the leadership matters a lot. So thank you for this presentation, Dr. Sood and Dr. Varvani. We've learned that strategy, you have to be strategic in everything that you're doing, teamwork, leadership, and communication. So we are happy to learn from you, Dr. Sood and Dr. Varvani, and the good things that you're doing in Mombasa. And we can clearly see the leadership that is in Mombasa County is, especially in the healthcare sector, is coming out very clearly. So I really hope this can be replicated to the other counties, that we are learning something, whether you're a CC in this forum, medical superintendent, public health officer, DMOH, that you're able to learn something, pick something, try implement something small. You might not have the full battalion of resources that you require. Probably you require a budget that is in millions, but the little that you can do with the resources that you have, as you request for more, let's start somewhere. So thank you, team from Mombasa. We've learned a lot. and continue doing good. We hope to continue learning more from you and copying from you. So thank you for that. I'd like to thank all the participants for attending today's session. And I really hope the sessions have been beneficial to you, that you've learned something, you've picked something. We might not be in a position to talk about COVID for a very long time, but I believe you've all learned something and you can implement something in your county, in your facility. So we appreciate that every time that you log in for these sessions, you're able to, we see feedback that you're learning something we appreciate, and we feel like we're doing something good. So have a good afternoon. Yes?
Dr. Kalondo, I had one more thing to say.
Okay.
There's a training that is being developed by the Ministry of Health related to the home-based isolation. So the counties should not feel that they just read the guidelines and they start implementing. There'll be a training that will take place maybe next week or the other week. The training material is being developed, which will include also how to use the Jitenge app. So the counties don't need to feel frustrated that they've been abandoned. There's a training that is being planned, and it will train the necessary people to implement and support the implementation of the home-based guidelines.
Okay. Thank you. Thank you for that, Dr. Mariti. And I hope the counties will be able to log on to that and learn something. So thank you all for attending today's session. We might not have had an opportunity to address all your concerns, but we appreciate the feedback that you've given Dr. Bhavani and Dr. Sood and the rest of the team from Mombasa. I'm sure they've been able to see. Some of your questions were a bit too patient related, and maybe we will at one point call the patients and just hear their feedback. Maybe they can share their experience, whether they preferred the home-based care vis-a-vis the facility care base, and we'll just get to hear their experience. So the patient sharing experience would be a good session to have. And there they'll be able to tell you, because I can see people asking who was the breadwinner, things like those. So those are some of the questions that we will hope the patients, once we're able to get a few to participate, they'll be able to share the experience with us. So have a good afternoon and see you tomorrow. Tomorrow we have a team from nutrition, and they'll be taking us through optimal nutrition for the patients. So as you implement home-based care, as they ask you, what food should I eat? What should I do? Log in for tomorrow's session and you'll be able to hear what advice to give the patient. So bye, thank you.
Bye-bye.